Hello everyone. Today we are going to talk about what's new in hyponatremia. I have given a topic on the same topic with a different title. Why are hypotonic parenteral fluids still being used in November of 2007? There are lots of things have changed since then. Let's go in detail. Hyponatremia is defined as less than 135 milliequivalent per liter. It is the most common electrolyte abnormality. According to the recent reports, almost 20% of all pediatric emergency visits have low serum sodium. 10% of hospitalized patients have hyponatremia. Almost two-thirds of patients admitted in PICU have hyponatremia. Hyponatremia can be lethal. It's not benign. The article published in 2010 shows the lowest mortality was identified when the serum sodium between 138 and 142. Virtually all hospitalized patients are at risk of developing hyponatremia. The main contributor is excessive free water intake. In presence of urgent vasopressin excess, administration of hypotonic fluids predictably causes hyponatremia. This article was published last month. Sodium fluctuation as the independent parameter predicting mortality in general hospitalized patients. They grouped the sodium fluctuation into 6 different groups. Each group varies from 0 to 6, 6 to 12, 12 to 18, so on and so forth till more than 30. Then they also grouped those patients came with normal serum sodium and those with abnormal serum sodium could be hypo or hypernatremia. They looked at the mortality. Mortality was high in both the groups, even with the fluctuations only up to 6 milliequivalents per liter. Across all groups, as you can see, the values were significant. So the sodium as a single parameter can predict the mortality in hospitalized patients. Let's look at the history. In 1953, hypotonic fluids were recommended by Talbot et al. They recommended 40 milliequivalents per liter. 4 years later, Holiday and Sager recommended 30 milliequivalents per liter in children. Most of them appreciated arginine vasopressin excess would impair water excretion. But they did not appreciate how common arginine vasopressin excess in hospitalized patients. I like to go and explain two terminologies it's important to identify or learn or understand hyponatremia. One is osmolality, another one is tonicity. What is osmolality? Osmolality is defined as the number of dissolved particles per kilogram of solvent. The normal range of serum osmolality is 285 to 295. Some books you would see 280 to 290, but it is very tightly controlled by hypothalamus. Sodium is the major determinant of serum osmolality. You will calculate serum osmolality like 2 times of serum sodium and serum potassium plus glucose over 18 and BN over 2.8. Then what is tonicity? Tonicity is effective osmolality and measures the concentration of particles which has the capacity to exert osmotic force across the membrane. Tonicity is determined only by solutes that cannot freely cross the semi-permeable membrane. Since urea can transfer across the membrane, that is removed from the equation, so sodium tonicity is calculated with the following formula: 2 times serum sodium plus serum potassium plus glucose over 18. This information provided or published by American Academy of Pediatrics. What are the commonly used fluids in children? Normal human plasma has a sodium of 135 to 145, osmolarity of 308. Hypotonic fluid still being used. 1/5 normal saline has 34 serum sodium, not serum sodium. 1/5 normal saline has sodium of 34. Half normal saline has sodium of 77. Normal saline has 154. Lactate ringers has 130 and plasma light 140. Only normal saline has serum osm similar to human plasma. Next close is plasma light. Let's go into the pathogenesis of hyponatremia in presence of arginine vasopressin. Three factors contribute to the development of hyponatremia. One, excessive water ingestion. Second, hypertonic urinary losses, meaning you tend to lose sodium in the urine. Third, impaired ability to excrete free water. In other words, retention of water. The body's primary defense against developing hyponatremia is the kidney's ability to generate dilute urine and excrete free water. When that one is impaired, retention of water happens that causes hyponatremia. Following slides will explain how that happens at the kidney level. The total cardiac output is filtered via glomerulus. In the proximal convoluted tubule, 2/3 of the water gets reabsorbed and also 66% of sodium, 50% of potassium, 90% of the bicarbonate, and 100% of the glucose. The descending loop of Henle is highly permeable to water, but less to sodium chloride and urea. The ascending loop of Henle is water impermeable, but sodium and potassium can traverse across. In the distal convoluted tubule, in the absence of ADH, it is impermeable to water. In other words, ADH promotes water reabsorption in distal convoluted tubule and also in collecting duct. Arginine vasopressin, otherwise called antidiuretic hormone, is secreted in response to osmotic stimulus. When the osmotic stimuli, when there is 1 to 2% change in the osmotic value, it stimulates the secretion of either secretion or shutdown of arginine vasopressin. There is a non-osmotic stimuli also works or promotes the secretion of arginine vasopressin. The most important being hemodynamic stimuli. When the blood pressure drops or because of bleeding or dehydration, arginine vasopressin is secreted in order to maintain the blood pressure or homeostasis. The most important thing we are worried about is non-hemodynamic stimuli. The non-hemodynamic stimuli are nausea, vomiting, pain, morphine, emotional states like anxiety, drugs, hypoxia, and the other reasons for SAADH. Almost 100% of the patients admitted in the hospital have either one of them or few of them of the non-hemodynamic stimuli. That means all hospitalized patients have non-hemodynamic stimuli to secrete arginine vasopressin. This picture depicts hemodynamic stimuli and non-hemodynamic stimuli. I just put this picture just to explain, not to bore you, because whenever you open the topic of hyponatremia, it has been divided into hyperosmolar, pseudohyponatremia, normoosmolar and hypoosmolar hyponatremia. Here we are going to just focus on hypotonic hyponatremia. That's where the origin in vasopressin excess or dependent low serum sodium level happens. As I explained before, most of the hospitalized patients have a reason for hyponatremia as a result of origin in vasopressin excess. So what are the diagnostic criteria for syndrome of inappropriate antidiuretic hormone? Let me explain what is inappropriateness. It's inappropriate to the serum osmolality. When the serum osmolality is lower or when there is hyponatremia, origin vasopressin should not secrete. But here, in these conditions, it tends to secrete even when there is hyponatremia. But it needs to fulfill the following 6 criteria. Number 1, patient should have a low osm, less than 275. They should have elevated urine osm, more than 100. The patient should not have hypo or hypervolemia. They should mean euvolemic status. There should be elevated urinary sodium excretion, more than 30 milliequivalent. Absence of other potential causes of euvolemic hypoosmolality like adrenal insufficiency and hypothyroidism. And they should have normal renal function and the absence of diuretic use. Since we talk about syndrome of inappropriate antidiuretic hormone, it's necessary to talk about cerebral salt wasting syndrome, which also you see in both in ambulatory and inpatient settings. Their mechanism is very different. SAADH, hyponatremia happens because of water retention. Cerebral salt wasting syndrome, the hyponatremia happens because of water depletion and also natriuresis. These patients also have kaliuresis. Brain natriuretic peptides that causes diuresis and natriuresis as a result, hypovolemia and hyponatremia in cerebral salt wasting syndrome. The treatment also differs. In SAADH, you reduce the IV fluids. In cerebral salt wasting syndrome, you give more fluid and more sodium. So what is hospital-acquired hyponatremia? Hyponatremic encephalopathy has been reported in healthy children and adults following routine surgical procedures. It's caused by a combination of non-osmotic stimuli for ADH release and administration of hypotonic fluids. The mortality has been estimated to be 8%. This picture shows how the brain adapts to the hypotonicity. The immediate effect of hypotonic fluid is water gain. As the hypotonicity or hypoosmolar state happens in the extracellular space, the water moves into the brain cells. The early adaptation is water extrudes out of the cells. Subsequently, the electrolytes such as sodium, potassium electrolytes, chloride also extrudes out. That happens within minutes. It goes on till 3 hours. And afterwards, the organic osmolytes within the neurons also extrudes out. During this time, improper therapy or rapid correction can cause syndrome called osmotic demyelination syndrome. This adaptation happens within 48 hours. That is called acute adaptation. When it exceeds more than 48 hours, we call it as chronic. The reason the 48-hour comes into play, by 48 hours, almost all the mechanisms play to keep the cell membrane intact during early adaptation or acute adaptation. When there is incomplete adaptation, that means it is not fast enough or the hyponatremia is so severe, then cerebral edema and subsequent severe symptoms ensue. After 48 hours, you usually do not see cerebral edema because at that time they reach the homeostatic level between extracellular and intracellular levels. The influx of water into the intracellular space leads to cellular swelling that results in cerebral edema and encephalopathy. It can lead to death and permanent neurological injury. Almost 50% of children with serum sodium less than 125 will develop encephalopathy. The numbers go up when the age is less. When the children are less than 2 years, 56% of them develop hyponatremic encephalopathy. When they are less than 6 months, 70%. When they are very little, like less than 1 month, maybe all of them will develop hyponatremic encephalopathy. What are the early signs? Anorexia, headache, nausea, and emesis. Very important to identify and treat accordingly when they have early signs. Some of them, in fact all of them, are very non-specific signs. But in presence of low serum sodium, we need to take into account and treat as CNS manifestations of low serum sodium. Advanced signs are impaired response to painful and verbal stimuli, bizarre behavior, hallucinations, obtundation, and respiratory insufficiency. 4 advanced signs are decorticated decerebrate posturing, bradycardia, hypertension or hypotension, altered temperature regulation, dilated pupils, seizures, respiratory arrest, and coma. The cardiovascular system, it can cause hypotension, renal failure, and tachycardia. Musculoskeletal, it can cause weakness and muscular cramps. What are the risk factors for encephalopathy? There are 3: age, hypoxia, and gender. Let's look at age. As you can see in the picture, there are 3 pictures: infant, adult, and elderly. If you look at the gap between the skull and the brain is very different in all those 3 pictures. So one of the most important reason for cerebral edema in small children, more common because of brain to skull ratio. These are the facts. The brain reaches adult size at 6 years of age. The skull reaches adult size at 16 years of age. Brain size starts decreasing at 30 years of age, and size starts decreasing faster around 60 years of age, meaning thereby the gap between the brain parenchyma and the skull is very tight when the children are younger than 16 years. In older individuals, you have a big space for the brain to swell. So cerebral edema will not get appreciated quickly in adults. On the other hand, chronic hyponatremia is more common in adults because cerebral edema symptoms is not obvious early on. In addition to the brain and skull ratio, the prepubescent children are more vulnerable because of low testosterone level. Testosterone does not promote adaptation, but the absence of testosterone affects the adaptation because of its effects on sodium potassium ATPase. In addition, sodium potassium ATP is also not matured in small children. The next is respiratory. Cerebral edema causes hypoxemia because of hypercapnic respiratory failure and also non-cardiogenic pulmonary edema. In the respiratory arrest can cause hypoxemia, and also non-cardiogenic pulmonary edema that could happen in cerebral edema patients can also cause hypoxemia. Let's look at this picture. A shows normal adaptation of cells, in this case, brain cells. When there is a low serum sodium, the extrusion of electrolytes happens, thus cell volume is maintained. In presence of hypoxia, the extrusion of electrolytes does not happen because hypoxia impairs sodium-potassium ATPase system. As a result, cytotoxic cerebral edema ensues when there is an hypoxia along with hyponatremia. This picture depicts mechanism of non-cardiogenic pulmonary edema in hyponatremic encephalopathy. As you can see, yes, as a result of hyponatremia, cytotoxic cerebral edema happens. Resulting increase in intracranial pressure can cause increased vascular permeability, which is centrally mediated. In addition, it can also cause catecholamine release, pulmonary vasoconstriction, elevated capillary hydrostatic pressure, and then capillary wall injury that can cause non-cardiogenic pulmonary edema. Both mechanisms, respiratory arrest and non-cardiogenic pulmonary edema, can cause hypoxia that impairs the brain cell adaptation by working through sodium-potassium ATPase. This is a picture about 144 patients with hypoxia with hyponatremic encephalopathy. As you can see, when you have low serum sodium and low arterial content, there is 83% chance of developing brain damage. This picture depicts hyponatremic encephalopathy and brain damage. 96% of those individuals had hypoxia. Almost 2/3 of them are reproductive age group females. And of course, small children, alcoholics, and liver disease. And finally, rapid correction of serum sodium. They all play a role, as you can see, hypoxemia being the #1 cause of brain damage when it coexists with hyponatremia. Gender. The relative risk of death or permanent neurological damage from hyponatremic encephalopathy is about 30 times greater for women than men. The risk is 25 times greater for menstruating females than postmenopausal females. This picture depicts morbidity mortality of post-operative hyponatremia according to sex. As you can see, most of the morbidity mortality happen in females than male, significantly higher. This particular picture depicts the factors that may contribute to the brain adaptation and its failure in patients with hyponatremia. Hypoosmolar state causes, when there is a normal brain adaptation in adults, causes asymptomatic hyponatremia. In children, because the high brain to cranial vault ratio causes symptomatic cerebral edema and thus brainstem herniation and death. In presence of estrogens, which is in reproductive age group females, and the hypoxia, the impaired adaptation, thus symptomatic cerebral edema and its consequences happens. Hyperosmolar state with cerebral edema can cause hypercapnic respiratory failure, neurogenic pulmonary edema that can cause hypoxia. In children with hyponatremia, often seen in patients with acute bronchiolitis or respiratory insufficiency, so even in the absence of cerebral edema, the pulmonary diseases can cause hypoxia that can impair the brain adaptation to hyponatremia. So you have to keep that in mind. So what are the risk factors? As we already discussed, post-surgical females of premenopausal age, children less than 16 years of age. Third, hypoxia. Fourth, brain injury, because these children or these patients already have vasogenic and cytotoxic cerebral edema. On top of it, hyponatremia. Further, the adaptation is impaired. And acute hyponatremia, the rapidity of the hyponatremia, so there is no time for the brain to adapt. So these are the reasons, these are all the factors causes hyponatremic encephalopathy in both adults and children. In addition to those factors, excessive vasopressin causes vasoconstriction of cerebral blood vessels, thus decreased cerebral perfusion, and also decreased oxygen delivery to the astrocytes, and decreased intracellular pH, cellular buffering, and also ATP and phosphocreatinine, the energy source for the neurons. In the postoperative setting, usage of hypotonic fluids. There have been more than 50 reports of death or neurological injury associated with hypotonic fluid in children. This is a report from 2005. 60 healthy children who died or suffered as a result of acute hospital-acquired hyponatremia. This was published in 1992. I just wanted to show certain facts from this publication. Most of these kids, their age varied from 1.5 to 15 years. These children are admitted for regular bread and butter of pediatrics, IV fluids, antibiotics, post-tonsillectomy, and operative setting of fractures. So regular pediatric inpatient hospital admission. The clinical outcome, either they died or sent home vegetative. Another editorial by Alan Arif, they showed there are 15,000 deaths per year as a consequence of post-operative hyponatremia. So it's not benign. The patients come here for elective surgery, you give hypotonic fluids in presence of excessive arginine vasopressin excess that causes hyponatremia and brain damage. There is no single fluid therapy will be optimal for all patients, so you have to keep that in mind. Academia Pediatrics recommends isotonic fluids for children above 28 all the way up to 18 years. This is recently recommended in 2018. In general, normal saline will not cause hyponatremia. There is a misconception that administration of normal saline as a maintenance fluid will result in acidosis. When you give 1.5 and 2 maintenance, yes, do happens, but when you are giving only 1 maintenance, chances are minimal. So how do you treat hyponatremia and encephalopathy? There are multiple recommendations in different years. In 1985, they recommended 20 milliequivalents per 24 hours. It's an optimal correction. 89, they changed it, and so on and so forth. Current recommendation still what is recommended in 2000, about 8 milliequivalent in the first 24 hours, and any 24 hours will prevent or avoid osmotic demyelination syndrome. Let's go in deep. So as you can see, there are no consensus, but these are all the facts. So relatively small increase in serum sodium concentration should reduce cerebral edema. Even seizures induced by hyponatremia can be stopped by rapid increase in serum sodium, in that average only 3 to 7. So immediately rising by 5 or 6 or up to 7 or 8 can reverse the cerebral edema and also stop the seizures. Most reported cases of osmotic demyelination syndrome occurs after rates of correction exceed 12 milliequivalent per day. There are isolated case reports of ODS, which is osmotic demyelination syndrome, occurs after correction of 9 to 10 milliequivalents per day. So the MADIAS and DADROG recommends the targeted rate of correction should not exceed 8 milliequivalent on any day of treatment. That was first published in NEJM 2000. It's re-emphasized again in 2022 by the same authors. So what are the risk factors for osmotic demyelination syndrome? There are 13 of them. I wanted to highlight the most important ones. One is rapid correction of serum sodium not exceeding 25 in 48 hours. That means 12 per day. And to be very safe, do not exceed more than 8 milliequivalent per day. Avoid hypoxemia, severe liver disease, alcoholism, malnutrition, and hypokalemia. All those factors can cause or predispose hyponatremic encephalopathy. So how do you treat? Give 2 cc per kilo of 3% saline over 10 minutes, maximum being 100. Repeat the bolus 1 to 2 times every 10 minutes. The goal is to raise the serum sodium to 5 to 6 milliequivalent per liter the first 1 to 2 hours. Recheck the serum sodium every 2 hours. Hyponatremic encephalopathy is unlikely if no clinical improvement following the acute rise in serum sodium of 5 to 6 milliequivalent per liter. Stop further therapy of 3% sodium chloride when the patients become symptom-free, that means awake, alert, responding to commands, resolution of headache and nausea, or acute rise in sodium of 10 milliequivalent per liter in the first 5 hours. Correction should not exceed 15 to 20 in the 48 hours, and also avoid normo or hyponatremia. I just want to show this slide. Intervene early to prevent CNS injury. So when do you intervene early? When there is any early symptoms like nausea, vomiting, headache. When there is late symptoms like seizures and respiratory failure, it's often associated with poor outcomes. There is a meta-analysis done. They comprises about 33 randomized controlled trials and 5,000 patients, comparing isotonic saline versus hypotonic fluids. As you can see, mild hyponatremia is prevented by giving isotonic fluids. Isotonic fluids prevents moderate hyponatremia. Isotonic fluids prevents severe hyponatremia. There is no role for hypotonic saline as a maintenance fluid and also during the post-operative state. Key points. Hyponatremia is very common. It's not benign. Do not use hypotonic fluids in hospitalized patients. Pay attention to urine output. Hypoxemia with hyponatremia is a deleterious combination. During correction, do not exceed 8 milliequivalents in any 24 hours. We'll go over the clinical practice guideline by American Academy of Pediatrics published in 2018. As you can see, 1/5 normal saline and half normal salines are categorized as hypotonic fluids. There is no role for them. Isotonic salines are normal saline, D5 normal saline in children, D5 lactate ringers, and plasmolite. Unfortunately, D5 plasmolite is not available in United States. I want to point out D5 lactate ringers has potassium of only 4 and plasmolite has potassium of 5. The subcommittee's recommendation is patients 28 days to 18 years of age requiring maintenance IV fluids should receive isotonic solutions with appropriate potassium chloride and dextrose because they significantly decrease the risk of developing hyponatremia. The quality of recommendation is a strong recommendation. With this, it concludes the topic on what's new in hyponatremia. Thank you so much.